The human body is defined by the sagittal plane, an anatomical midline that separates the left side from the right. In medical diagnosis, this boundary is the primary point of clinical orientation. In the world of ICD-10-CM coding, this physical divide is governed by a specific set of instructions, Guideline B.13, Laterality. The rule is direct. A coder must identify whether a condition affects the left side, the right side, or both. If the medical record provides this detail, but the coder fails to apply it, they are forced to use unspecified codes, a practice that creates significant compliance risks during an audit. Modern payer systems often require specific laterality to process a claim. When the documentation supports a side, but the code does not reflect it, the resulting data mismatch is a primary driver of claim denials. To master this, we are building a decision matrix, a logical framework designed to handle single visits, long-term care, and even missing or conflicting physician notes. Precision in laterality is a mandatory requirement for translating clinical reality into the compliant data needed for healthcare reimbursement. Our matrix begins with a baseline axiom: always choose the code that explicitly reflects the documented side. Many ICD-10-CM codes are built to include this information, offering specific alphanumeric characters for right, left, or bilateral conditions. However, you will encounter situations where the physician documents a bilateral condition, but the coding manual does not provide a single bilateral code for that diagnosis. This creates a gap. How do you accurately code a bilateral condition using only unilateral options? In these cases, you must apply a specific workaround. Point 2 of the guideline requires you to assign 2 codes instead of 1, a code for the left side and a separate code for the right side. The matrix also accounts for the opposite problem. What happens if the physician fails to document the side entirely? Point 3 permits the use of an unspecified side code when the record is silent, but use these with extreme caution. Insurance algorithms flag unspecified codes for review, as they often indicate incomplete documentation. Relying on these codes is often a sign that available clinical data in the record has been overlooked. An effective coder works to avoid the unspecified branch whenever possible. These baseline rules ensure that every initial encounter results in a definitive choice between left, right, or bilateral, removing ambiguity from the claim. Coding accuracy must also be maintained over time as a patient returns for follow-up care. Laterality is highly dynamic. The correct code during the first visit may be incorrect by the second visit. Consider a patient who presents with a bilateral condition, something affecting both ARBs. According to point 4, if the condition is present on both sides, you assign the bilateral code. This rule holds true even if the doctor only treats one of those sides during the visit. The bilateral code reflects the patient's current state, not just the focus of the procedure. Now, move forward to the follow-up visit. At this stage, your code must reflect the patient's clinical status at the moment of the encounter. If the previously treated side has resolved, the condition is no longer bilateral. Point 5 states that once one side is clear, the bilateral designation no longer applies. You must transition your coding from bilateral to unilateral, reporting only the side that remains affected. However, if the condition persists on both sides because the initial treatment was unsuccessful, Point 6 clarifies that since the clinical status has not changed, the coding logic remains the same. You continue to assign the bilateral code. Failure to adjust these codes as a condition resolves is a leading cause of denials for follow-up care. Multi-encounter coding requires constant reevaluation to ensure the code matches the current physical reality of the patient. Let's return to the most common obstacle, a physician note that fails to mention the side. Before defaulting to an unspecified code, there is a protocol to find the missing data. Point 7 allows you to use proxy documentation. You are authorized to extract laterality from other clinical notes within the same medical record, such as a nurse's intake assessment or a radiologist's report. But this can lead to data conflicts. For example, if a nurse notes the right side, but a therapist documents the left. When documentation conflicts, point 8 applies. Firmly, a coder cannot resolve this conflict by simply picking one clinician's word over the other. You must pause the coding process and issue a formal query to the provider for clarification. This leads to point 9. Unspecified codes are the final option, used only when documentation is insufficient and your query for clarification goes unanswered. This query mechanism functions as the final checkpoint for accuracy, verifying the clinical facts before they enter the billing cycle. Your role is to actively investigate these gaps, ensuring the medical record is both complete and accurate. This completed decision matrix provides a clear path through missing codes, changing conditions, and conflicting notes. To simplify this for daily use, we use a mental heuristic called an MJ-GEM. The core rule is left, right, or both. You must be specific. For long-term care, remember, bilateral stays until one side is gone. Before submitting any chart, confirm the side affected, check for any clinical changes since the last visit, and verify that your code reflects the current status. Consistently applying guideline B.13 produces data that is precise, compliant, and defensible under audit.